Good evening and welcome to the Updates on Thyroid Cancer webinar. It gives me great pleasure to invite our program coordinator, Dr. Somnath Roy, to give the opening and welcome address. Over to you, sir.
Yes, good evening, everybody, my colleagues and all the entire organizer team to arrange a program on updates on thyroid cancer. Basically, thyroid cancer is a cancer when there is a multidisciplinary approach is there. Particularly, we need surgery is the cornerstone of treatment, and the other part was nuclear medicine like radioiodine uptake scan, radioiodine scan, and radioiodine ablation therapy. The role of radiation and the role of chemotherapy, like targeted therapy, is a very minimal, and it was the last resort when patient is radioiodine refractory. But still, there is some upcoming data like management of thyroid cancer in terms of molecular basis in the histology, and there is mutational status, and there is a recommendation of TKI like lymphatinib, sorafenib, cabozantinib, let's on going on. So it is just a review, and we discussed to all of us to rapid brush up of management of thyroid cancer. Particularly, we are discussing a panel discussion with all of our eminent surgeon and nuclear medicine consultant is there. And we have a talk of role of TKI in the management of radioactive refractory differentiated thyroid cancer. Dr. Joydeep Ghosh is a consultant of our colleague in Department of Medical Oncology in TMC. He will deliver a lecture. And then, but after that, a short discussion of thyroid cancer with our eminent panelists. So over to Himangsi for introduction and invite the speaker.
Thank you, sir. I would now invite Dr. Joydeep Ghosh, Consultant Department of Medical Oncology, TMC, Kolkata, to give a talk on role of TKI and radioiodine refractory differentiated thyroid cancer. Over to you, sir.
Yeah, thanks, Himanshi. I'll just share my screen. Just give me a moment. Okay, Himanshi.
Yes, sir.
Yeah, you might have to
Sure, sir. I'll stop sharing.
Yeah,
Okay, so I'll share it
from my side.
So should I share the presentation, sir? You
Yeah,
can say
please
next
share
whenever you want.
Yeah,
Sure. Yeah. Okay, sir.
So, good evening, all my dear colleagues, seniors. So, today we'll have a short brush up of thyroid cancer, especially since I'm a medical oncologist. I'll focus mostly on the advanced stage, and this is one area which is not much commonly dealt in most of our seminars. Most of the seminars are about breast, lung, and gynecological malignancies, but this is something that we need to revise at regular intervals because the overall outcome and everything is much better than many other solid tumors. So with that short background, so basically if we start off, largely it revolves around the diagnosis and pathology as well as the molecular biology. uh, Obviously, when there is a thyroid nodule, it is the surgeon, head neck surgeon, whom we refer to the patient first, and they are the ones who usually does the workup. And I think they're much better in doing the initial workup, and our role comes much later when the surgical treatment as well as the radioiodine therapy has failed. So a few words about the molecular tests that needs to be done. Well, as of now, in the curative setting, there is not much well-defined role of doing molecular analysis upfront. But if you are trying to find out any familial background to your thyroid cancer, you can always go for the red mutation and all those things. But otherwise, from the treatment perspective, there is no role of doing molecular tests at baseline when the patient is in the curative setting. But regarding the palliative setting, definitely there is upcoming role of BRAF mutation, NTRK mutation, and all those things are there. So that is something that that is useful after 1 or 2 lines of TK when we do not have any other treatment options. So moving ahead, next slide. So this is a flow diagram, basically the approach to the diagnosis of differentiated thyroid cancer. This was from the using the eighth AJCC staging, and this is very clear. And this is the routine practice that we have in most of the situations. We initially need to stage the thyroid. If it is localized disease, we do the tissue diagnosis and go ahead with surgery, followed by radioiodine diagnostics to see whether there is any other metastatic disease or not. And if it is upfront stage 4, obviously the patient, the treatment paradigm changes significantly. Next slide. And this is the American Thyroid Association risk stratification. I'm not going to the details. This is there in the routine. It's there in the website, so you can go through it anytime. Next slide. And surgical management, well, I think there are better people in this panel to discuss the surgical management, and I would skip this slide. Next. Regarding the ESMO updates about radioactive iodine therapy, we have Dr. Somnath Roy here. He can also give his inputs after the talk. But treatment with radioiodine therapy more than equal to 100 mCi is the recommended for patients with high risk of recurrence. And it should not be used for low risk patients with an intrathyroidal DTC less than 1 centimeter and no local regional metastasis. And it may be recommended for other low risk cases on an individual basis, in a case-to-case basis, MDT discussion. And radioiodine adjuvant therapy can be considered for intermediate risk, and decision on dosage and TSH stimulation need to be decided on a case-to-case basis. Next slide. And patients with a distant metastasis, as shown in the previous slide, should receive 100 to 200 mCi of 131 after TSH stimulation every 6 months for radioactive avid distant mets with levothyroxine treatment, levothyroxine between treatments to maintain a serum TSH, because this is very important. Unless we maintain a very low TSH level, less than 0.1, it's difficult to have the optimal effect of the radioiodine therapy. And for lesions persisting after a cumulative dose of 600, that is the time when the role of the medical oncologist comes in, and those are basically radioiodine resistant thyroid cancers, and and there starts the role of the TKIs. Next slide. And this is a flow chart showing the response to therapy classification of patients with DTC treated with total thyroidectomy and radioiodine therapy. Next slide. Next slide. Yeah, there is some role of EBRT, but again, EBRT has not established its significant impact in the treatment of thyroid cancer. Most commonly where radiotherapy comes in is if we have a very locally advanced anaplastic CA thyroid where surgery is out of question, and obviously systemic chemotherapy is the way forward. But since these patients have a lot of local symptoms, so maybe to palliate these symptoms, you can use radiotherapy, but otherwise there is not much role of radiotherapy in thyroid cancer. Next slide. Next slide. Yeah, so coming to the radioiodine refractory advanced or metastatic thyroid cancers, we usually classify these patients based on their symptom burden. If they are asymptomatic and stable disease, a good option is follow-up. So I'll just give a practical example. Like if we have a patient who is radio resistant, but say there are 2 very small tiny lung nodules with an elevated thyroglobulin, patient is completely asymptomatic, and the nodules would have never got picked up if we didn't do the scan. So in these situations, there is a room for active surveillance and not doing anything for these patients. But on the other hand, if we have a patient who is rapidly progressing, for example, if we are keeping the patient under active surveillance and at regular intervals, we see that the number of lesions are increasing, or one of the lesion is adjoining some major structure which might actually cause some symptoms. In those situations, we need to start the patient on systemic therapy, especially if they have multiple lesions. It is the systemic TKIs which is the first treatment of choice. But if there is a single lesion, Like suppose we have a small lung nodule or a mediastinal node which is abutting right near the trachea, there is an option of giving local therapy in the form of radiotherapy to palliate the symptom and observe rest of the disease. So that option is there. But if it is an extensive metastatic disease, obviously the treatment of choice is oral TKI, which I'm coming to in the subsequent slides. Next slide. And this is the NCCN guidelines for treatment of thyroid cancers. So if we look at the level 1 indications for progressive and symptomatic disease, it is lenvatinib preferred or sorafenib. Also, we have the role of cabozantinib coming up if progression happens after lenvatinib and or sorafenib. Also, NCCN, as I was previously mentioning in my first slide, that there are a couple of molecular alterations like NTRK and BRAF and all those things have come up, and also people have started doing the tumor mutation burden in thyroid cancers, and they have also started to investigate the role of immunotherapy drugs like pembrolizumab. So those options are also there. So if the patient has an NTRK fusion protein positivity, you can go for larotrectinib or entrectinib. You have the option of giving selpercatinib or prasletinib for RET fusion proteins. And if you have a patient who is having a high tumor mutation burden, more than 10 mutations, which is very commonly done in many in many other cancers also recently, you can consider giving them pembrolizumab after initial lines of therapy. Next slide. This is mostly about the bone metastasis and the CNS metastasis, which is in line with the standard bone and CNS directed therapies for all the cancer, all other cancers. Next slide. Yeah, coming to the evidence that we have for the TKIs that are commonly used in routine practice. This is the most important SELECT trial. So in this SELECT trial, people looked at the role of lenvatinib versus placebo in radioiodine therapy. Now, question might arise that why placebo? The reason behind is that when this trial was designed, sorafenib was probably not the standard of care. The standard of care after radioiodine therapy was nothing. So that is the reason why the standard arm was standard arm was placebo and not sorafenib. If this trial got designed now, it will definitely be either sorafenib or something else. So patients who were radioiodine refractory thyroid cancers, for example, those who have had a radiological evidence of disease progression within 12 months prior to randomization. And also, I would like to mention here, it's not mentioned in the slide, that patients who had received more than 600 MCI of radioiodine, and still the patient is progressing. In that situation, also there is a role of lenvatinib as a treatment. So the randomization was 2:1. Patients received lenvatinib at 24 milligram once daily versus placebo, and the time to disease progression was it was continued to till the disease progression, and the primary endpoint was the progression-free survival. Next slide. And these are the baseline characteristics. You can see that 261 patients versus 131, since it's a 2:1 randomization. Females comprised of approximately half of the patients in both the groups. Majority of them had good performance status, and 25% of the patients actually had prior TKI. So this prior TKI in all the cases has been sorafenib, because that started coming up in one of the trials. And obviously it doesn't comprise of a significant chunk. So mostly like 3/4 of the patients were treatment naive, TKI naive. And if you look at the histopathological subtype, papillary was the most common, followed by poorly differentiated and follicular. And obviously, concurrent with the routine clinical practice, the lung and the lymph nodes comprise of the most common metastatic site in this trial. Next slide. So fantastic. I mean, very rarely do you see such Kaplan-Meier curves in medical oncology. But yes, the disclaimer here is the standard arm is doing nothing. So doing something is obviously far, far better than doing nothing. And especially when you have a drug like lenvatinib, which has a very decent amount of response rate, both not just in thyroid cancer, but also in HCC. We have seen that the response rate of lenvatinib is far better than sorafenib in these two settings. So if you look at the median PFS, it was definitely far better with lenvatinib compared to doing nothing. And there was almost an 80% reduction in the risk of disease progression or death with lenvatinib, with a very favorable hazard ratio of 0.2. Next slide. And also, if you look at the response rate, the lenvatinib arm had a 65% response rate versus no response practically in the placebo arm. And 2% of the patients actually had a complete response. So that is really encouraging. Next slide. And since overall survival was the secondary endpoint, and the median overall survival was not there, it did not reach at the data cutoff. And if you look at the median OS in months, it was not reached in either arm. So this again tells us that this is a good disease, and it doesn't kill our beloved patients fast. It takes long time, but we need to see the mature results of this trial to have an idea about the overall survival, because that is something that will be helping us to counsel our patients accordingly. Next slide. And if you look at the PFS across age, so the patients who had who were less than 65, the lenvatinib had 20 months versus 30 months. And patients who were more than 65, the median PFS was 16 months versus 3.7 months. So in both less than 65 as well as more than 65, the drug seems to be working. Next slide. And this is they have also analyzed the OS across the age. On the left side, you can see that patients who are more than 65, their OS curves actually have started separating much earlier, and they stay separate till the last. But patients who were less than 65, their curves are more or less overlapping on each other. So I really do not know what can be the cause of this differential overall survival based on the age, maybe the tumor dynamics, maybe other factors. But yes, probably in the elderly, the overall survival tends to be better with this drug. Next slide. And regarding the adverse events, well, the routine common adverse events with lenvatinib are hypertension, GI intolerance in the form of diarrhea, anorexia, sometimes mucosal ulcers, and some patients do develop a bit of hand-foot syndrome and also skin rashes, but most of them are manageable. In some of our patients, we have seen that managing hypertension becomes difficult. We have to modify the dose of the drug. But when it comes to GI toxicity, a large chunk of our patients actually had to reduce the dose of the drug because of the GI toxicity. And I honestly do not remember any patient of mine who is getting lenvatinib and is tolerating at 24 milligram dosing. But if you look at the trial, a large chunk of the patients actually tolerated the 24 milligram dose. So probably there is some difference maybe in the pharmacodynamics between the Western population and our patients. Next slide. And there is some update on this drug. So there is a prolongation of response in lenvatinib responders with thyroid cancer. So this paper was published in the endocrine related cancers, not a very major journal, but it again helps us to support the SELECT-D Kaplan-Meier curves, because the curve is exactly similar to the SELECT-D trial. Next slide. So this was basically the multivariate analysis or the baseline characteristics of the patients in this study. And if you look at some of the patients actually had prior VEGF therapy, but majority did not have a prior VEGF therapy. So this is more like a treatment naive population that we are looking at. Next slide. And these are the response rates in this particular trial. So if you look at the partial response, almost 58% of the patients, so almost 60% of the patients had a partial response, which is just like the same as we have seen in the SELECT trial also. Next slide. So the updated analysis shows that patients who responded to lenvatinib continued to have a prolonged and durable response, and the prolonged duration of response was observed across the several patient subgroups. The duration of response was similar among patients who had prior anti-VEGF therapy versus those who did not. And adverse management, of course, we need to do a judicious management of adverse effects so that we can have the optimal dosing for these patients. Next slide. Now, coming to another drug, that is the cabozantinib, and this is a cosmic trial, which is again a phase 3 randomized trial comparing cabozantinib versus placebo after prior VEGF or TKI. Next slide. So why this is important is because after one line of TKI, 1 or 2 line of TKI, there was practically no treatment option for these patients. So cabozantinib in this cosmic trial has been tested in this particular setting where we have already wasted 1 TKI, 1 or 2 TKIs, and the patient is progressing. Next slide. So this was a trial design, 60 milligram versus placebo. Again, it was a 2:1 randomization, and patients could have got prior lenvatinib or sorafenib. And the patients were continued on cabozantinib 60 milligram till disease progression. And the co-primary endpoints were PFS by the independent review and overall response rate by the independent review. Next slide. These are the baseline patient characteristics, which was more or less similar in both the arms. What is interesting is regarding the prior treatment. So 37% of the patients received sorafenib, 40% received lenvatinib, and 23% of the patients actually received both sorafenib and lenvatinib, probably sequentially. And patients who did not receive, the number of TKI lines that the patients received was 74% one line and 25% 2 lines of TKI. So this is relatively more or less sort of a second line treatment, I would say, for thyroid cancer. Next slide. And if you look at the median PFS by independent review, it is 11 months versus 1.9 months, again with a hazard ratio which is exactly similar to the previous first line trial also. Next slide. And if you look at the PFS by prior therapy, there also for patients who had prior therapies, there was a very favorable hazard ratio, be it either lenvatinib or sorafenib versus be it lenvatinib plus sorafenib. So be it in the second line or in the third line, the hazard ratio is very favorable with cabozantinib. Next slide. And these are the adverse events. So most common adverse events we need to keep in mind are the hand-foot syndrome, loss of appetite, nausea, and a bit of liver dysfunction in the form of elevated transaminases. Next slide. So the conclusion from this trial is, after 1 or 2 lines of TKI, the standard of treatment now becomes cabozantinib rather than best supportive care. And also, if these patients have a symptom burden, since the response rate is quite favorable, so they will have some bit of palliation in their symptoms also. Next slide. So to summarize, most important factor is the TSH suppression that I'm sure our nuclear medicine expert would also highlight on that. And the imaging that we routinely do can be CT scan, and we usually use the RECIST criteria in the CT scan to assess our progression or response. Obviously, lenvatinib or sorafenib is the first line treatment. Now, how I decide is that they have not been compared head to head. Sorafenib was better than placebo, lenvatinib was better than placebo. But the response rate of lenvatinib was far better than sorafenib. Sorafenib response rate was around 10% in the initial trial, the decision trial, but lenvatinib it was around 60 to 70%. So obviously, that is the better drug of choice. And now with the advent of generics, the price of lenvatinib has significantly come down. So it can well be the first drug of choice. Next slide. So thank you. Over to the organizers.
Thank you, sir. Moving on, I would like to invite our moderator, Dr. Somnath Roy, Consultant Department of Medical Oncology, TMC Kolkata, to moderate the case-based discussion on Multidisciplinary Tumor Board on Thyroid Cancer. Our panelists are Dr. P. Arun, Dr. Prateek Jain, Dr. Somendranath Roy, and Dr. Kapila Manikantan. Over to you, sir.
Good evening, everybody again. Himangsi, am I audible?
Yes, sir, you're audible. So all the panelists have logged in.
Okay. And am I? The video is also clear, na, I think.
Yes, sir. So we can see you as well.
Okay. So just share the slides from your end. I will go to the next, and then I'll call our panelists one by one. Okay.
Sure, sir.
Okay. And before going to the discussion, thanks to Dr. Joydeep for introduction. Is a good lecture of TKI in thyroid cancer, and thanks to all of our panelists, esteemed panelists, to participate in this event. And thanks the academic, our partner, Mr. Subhajit is there, I think, for support and these things, organizing the event, and all the entire organizing team, Himangshi and others also. So today we discuss our case-based. Basically, it is a discussion of our day-to-day practice, just not like a question answering session. It is just an interaction with our colleague to how to deal, how to approach with our patient in future in when discussing when we are dealing with such kind of tumor. Because I have seen lots of patients who was there in our OPD who came with us with a differentiated thyroid cancer, who's are almost very advanced stage. So next slide, please. So it is basically it's a virtual is a case given from the organizer. It is a just for discussion. Is a 67-year-old woman with a painless lump in the neck. Past medical history is unremarkable. Physical examination is a palpable thyroid nodule, solitary nodule in the midline of the neck mass. Next. So workup, what do you plan in this case would be definitely we have routine workup we have done. And next slide. So we'll do the TSH, anti-thymoglobulin levels, and ultrasound of the neck. Reveal 3.6 centimeter mass lesion in the thyroid with 3 suspicious supraclavicular nodes, 0.2 centimeter in size. An ultrasound guided FNA of the thyroid mass revealed is a papillary thyroid carcinoma. And the FNAC from the supraclavicular node is also positive for thyroid cancer. Next. So patient is otherwise fit and good enough. So now my question to Dr. Arun is, sir, in your clinical practice, what is the indication of total thyroidectomy with central neck dissection in a patient with comes with us with a papillary thyroid or follicular, whatever differentiated? I'm not talking about the anaplastic one or medullary, but a differentiated thyroid cancer who is fit enough. Dr. Arun, please.
Thank you, Somnath, for introducing this case. So from what you presented in the history, it's a patient who is elderly, 67. So the cutoff age according to AJCC 8 is 55, which would change the staging. So that is important to remember, that magic number 55. So this patient is on the other side of 55. She's around 60. And you say that she comes with a midline swelling. So unless otherwise proven, you would suspect a thyroid. It can be a multinodular goiter. It can be a benign thyroid nodule. But as you put in an elderly patient presenting with a thyroid swelling, you have to exclude a malignancy. The triad of investigations which we usually start with are, we don't do a thyroglobulin in all these patients. We would do a TSH, which is to assess the function of the thyroid. And ultrasound is the gold standard investigation. Here, the ultrasound has revealed nodes in the supraclavicular area. And so that is an indication, because thyroid can throw mets in a variety of areas in the neck. And you won't be surprised if you get something in the retropharyngeal area. It can even, there can be nodes going right up to the skull base. There would be nodes going into the mediastinum. So here I would choose some sort of cross-sectional imaging if there are nodes. And the third test which we would do to start with is an FNAC. And FNAC, thyroid FNACs are very sensitive and specific. And there's a lot of experience, even pathologists just out of their training would be able to tell you if it's a papillary thyroid carcinoma. Follicular is a different matter. You cannot diagnose a follicular carcinoma from an FNAC, but a papillary, yes. Now come to the next question. When would you do a total thyroidectomy? So the answer to that is the standard operation for carcinoma thyroid is a total thyroidectomy. You would extend the operation to include the central compartment or the lateral compartment, considering the extent of it. The question of whether you want, when would you do a central compartment? That was what Dr. Somnath had put for the central compartment. Many surgeons are very hesitant to go into central compartment, mainly because you lay bare both the recurrent laryngeal nerves, and as you know, these recurrent nerves move your vocal cords. And more importantly, the parathyroids remain in the central compartment. A lot of studies which say that when the central compartment is dissected, there's a high incidence of at least temporary hypocalcemia, and some papers even permanent hypocalcemia. So the indication, so doing it prophylactically is still a matter of debate. So many centers with a lot of experience, very confident surgeons will do a prophylactic central compartment, but there are many people who would be very hesitant to do a prophylactic. Having said that, if there is a node which is detected in the central compartment at surgery or on investigation, you would definitely do one. So the indication for doing a central compartment is presence of a node in the central compartment, presence of a node in the lateral compartments, anywhere between level 2, 3, 4 on the jugular chain or the supraclavicular nodes which were detected here, you would do a central compartment if there are nodes elsewhere. The third indication would be if there is an extrathyroid extension, so the tumor is aggressive, it is involving tissues like the strap muscles, you would go and do a central compartment. And the fourth time would be any tumor more than 4 centimeters. So larger tumor tend to send off more nodes into the central compartment. So if any of these criteria are met, we would do a central compartment. Otherwise, we pick ourselves to a total thyroidectomy. In this case, since there are nodes present, we would extend our operation into the lateral compartment also. So here, it would involve a total thyroidectomy, a central compartment dissection, as well as a lateral compartment. So there is no role for prophylactic surgery for neck dissections. So the nodal stations involved, it's from the history, I hear it's on one side. So I would do a comprehensive neck, the supraclavicular, for at least 2, 3, 4, 5. I would also assess the thorax in this case, because these are low nodes, high possibility of having mediastinal nodes. And if they are evident, I think the effort should be, because thyroid is a surgical disease mostly. I would go and chase the disease down into the mediastinum as well.
Okay, thank you, sir. Thank you so much, sir. Dr. P. Arun is a consultant medical oncologist, consultant head and neck surgeon, and a head of the department in head and neck surgery in TMC Kolkata. Sir was routinely doing thyroid surgery also. So thanks, sir, for your input and this our case-based discussion in the thyroid cancer with a recent role of prophylactic as well as central net dissection. So my next slide, please. So next. So this patient is underwent total thyroidectomy with central compartment and right selective neck dissection. It was a 3.6 centimeter papillary thyroid cancer arising from the right lobe of thyroid. It's and 2 to 6 node positive with the central compartment. So is a positive extranodal extension also there. So it is a T2 N1 X, mostly M0 with a good performance status, is a thyroid cancer. Next slide. So my next question to Dr. Somendranath Rai. Dr. Somendranath Rai is a consultant nuclear medicine in TMC Kolkata. Sir was practicing quite long ago with and dealing with the thyroid cancer day-to-day basis. So my question to Dr. Rai is, in this case, if it is a T2N1 disease with a node positive disease and patient is surgery done, total thyroidectomy, central neck dissection. So patient comes with you. So what is your investigation of line of investigation or a line of management in this case, basically? Dr. Rai, please.
Yeah. Good evening, everybody. Am I audible? Good evening.
Yes.
Yeah. Am I audible?
Yes. You're audible.
Yeah. Good evening, everybody. So the line of management in this case is definitely iodine 131 diagnostic workup and followed by radio-iodine therapy. And she is definitely a candidate for high-dose radio-iodine therapy because most of the things were not in her favor. As Dr. Arun has just mentioned, age was not in her favor. She was 67, and if you remember that number, 55. Thyroid is one cancer, differentiated thyroid carcinoma is one cancer where age comes to staging. And then there is a bad histology. The tall cell features were there. There was nodal involvement and supraclavicular node was involved, which was quite low in the patient's system. Not only in the neck, the lower nodes, the lower neck node like supraclavicular node was also involved. So taking everything into consideration, we will definitely consider high dose radioiodine therapy in this patient.
Okay.
Yes.
Okay. So thank you, Dr. Rai, for your input. Just we are moving on lots of discussion in this case, not in this case. Next slide, please. So my question is, I'm coming to the later. Just my one question. Dr. Pratik is there?
Yes, Dr. Somnath, I'm here.
Yeah. Good evening, Dr. Pratik. Dr. Pratik is our consultant head and neck surgery in TMC Kolkata, is our colleague. So my one question is, if patient comes with a lots of metastatic disease upfront, like is a papillary thyroid cancer or follicular thyroid cancer with metastasis to the neck nodes, as well as the workup CT scan reveal there is a nodule or metastasis in the lung with a very symptomatic disease and compressing the great vessels or trachea. There is some respiratory difficulty was there due to huge nodule in the thyroid. So in that case, is there any indication of debulking surgery upfront in a metastatic differentiated thyroid cancer? Just keep it brief.
Yes. So good evening, everyone. Definitely, if there is a differentiated thyroid cancer, even if it's metastatic in nature, we would go ahead with total thyroidectomy, and if there are any nodes, you should take it out. As much disease as you can reduce surgically, you should take it out, and rest of the lesions would be taken care of by the radioiodine. But as long as your thyroid is still there in patient's body, your radioiodine will be concentrated in the thyroid gland itself. So it is always preferable that if thyroid is operable without much of morbidities, you should try to take it out, considering that there is your recurrent laryngeal nerves are always at risk. So if during surgery, if you find that one of the nerves is involved in the tumor, you should always try to preserve the other side nerve, but try not to damage both nerves. So if you find that the disease, if in these situations you should operate the side where you have lesser amount of disease first, and see if you can preserve your recurrent laryngeal nerves in that area. You can preserve the parathyroids in that area on that side, and then only go for the other side where the disease is likely to be more advanced.
Okay, correct. Thank you, Dr. Pratik, for your inputs and thoughts with this discussion. Thanks a lot. So, my another question to Dr. Kapila. Dr. Kapila is there?
Yeah, I'm here.
Yes. Good evening, Dr. Kapila. Dr. Kapila is also consultant head and neck surgery in our TMC Kolkata. Is our colleague. So one question of mine in my mind. So during the total thyroidectomy and
Hello.
How you preserve regarding address the parathyroid, because it is an issue of total thyroidectomy, the parathyroid preservation, or is a chance of late complications. So just have a thoughts regarding preservation of parathyroid or these things regarding total thyroidectomy and things. Dr. Kapila.
Yeah, thanks for raising that. Yeah, so preservation of parathyroids is very important, especially in thyroid surgery, because it can result in significant morbidity for the patient. So as a routine practice, we dissect as close to the thyroid gland as possible. Identification is most important. It's not just important to preserve the parathyroids, it's also important to preserve your blood supply. Otherwise, you're just preserving a dead parathyroid there. Another important thing is, if you find that it is devascularized, you will realize it on table itself. So it will become congested. And if it's congested also, there's no sense in preserving it. You rather excise the parathyroid, you macerate it, and you insert it into the sternocleidomastoid, which is the easily available muscle right next. So that is the simple way of doing it. If available, there are lots of new methods to identify the parathyroids. One of it is the ICG dye, and you can use this in the specialized equipment for that. You're using a camera where it highlights the, you don't need the dye itself.
Near infrared.
Near infrared, sorry. So I missed that. The near infrared camera is there. So which helps you to identify even without the dye. The dye helps you in identifying if the vascularity is preserved. So you can use that. There is also other dyes which are available. It is a coal-based dye, which is, there are lots of studies on that, which is going on in, which has been published from China. So these things will help you in improving your identification and preservation of your parathyroid glands. So the best way is to preserve it, and you also have to have a good idea of the anatomy, as the parathyroids may be very variable in their location. So right from high up, the level of the hyoid down into the mediastinum. So identification as well as knowledge of the anatomy is very important for preservation of the parathyroids. Another important thing is that both checking the parathormone levels pre-op, post-op, and also in a follow-up in a couple of months will also help in having a knowledge of whether the parathyroids are recovering after preserving or after transplant. Thank you.
Okay. Thanks, Dr. Kapila, for highlighting this, because it is also an issue regarding parathyroid preservation during total thyroidectomy surgery, and we have to think about the late complication of this. So moving ahead, again, what is the Dr. Rai? My next question is Dr. Somendranath Rai. So dose of levothyroxine in post-surgery. So what is the algorithm on what do the prefer? Because anyhow, patient after total thyroidectomy, patient will have lifelong levothyroxine. So what is the dose titration? What is the initial dose, and how you escalate or de-escalate regarding based on your clinical practice, please, Dr. Rai.
Yeah. So to decide about the dose of levothyroxine, we'll have to look into the TSH value, and the other clinical features. We need to supplement thyroxine for two reasons. Number one, the patient is not having any thyroid hormone, physiological thyroid hormone in his or her body. So we'll have to replenish that thyroid hormone. And second thing, we will have to keep TSH adequately suppressed to get rid of the TSH stimulation factor. Now, the latest recommendation of ATA, American Thyroid Association, for high risk and intermediate risk thyroid cancer said that TSH should be suppressed below 0.1 microinternational unit per ml. And for low risk thyroid cancers, it can be kept in the slightly below than the normal range. Like it may be kept in between 0.1 to 0.5 microinternational unit per ml. But these are recommendations, but practically in the clinical setting, and especially when you are dealing with an elderly patient, you will have to take many other factors into consideration. Thyroxine apparently is a physiological hormone, but it is also not free of side effects. It leads to tachycardia. In some cases, it leads to arrhythmia. Then thyroxine-induced osteoporosis are also not uncommon. Many patients report, who are in the relatively higher range of thyroxine for adequate thyroxine suppression, they have iatrogenic tremors. So taking into consideration, you will again have to judge the dose of the thyroxine case-to-case basis and keep it adequately suppressed. Yes, Somnath.
Yes. Thank you, Dr. Rai, for your insight. So moving ahead, next slide, please. Next slide. So patient was treated with radioiodine 100 millicuries with a whole body scan showed uptake in the neck only, consistent with the thyroid remnant. Next, please. Next slide. Yes. So it is another question is in mind. When a patient is a residual disease in the neck in thyroid scan, post-operative radioiodine scan, there is a residual disease in the neck. So my first questions would be to Dr. Arun. Sir, there is any role of post-therapy residual disease, any role of surgery, neck dissection or these things in this case, or not in this case, basically in our routine practice? Residual, how we address residual disease in the neck in differentiated thyroid cancer?
Great question, Somnath. This is a situation which we face quite often. But here, I must add that when you do the iodine scanning after thyroidectomy, it is natural to find some uptake in the neck. This is not an indication of bad surgery or remnant disease. So usually the thyroid is very, very tightly stuck to the trachea. It's called the Berry's ligament. And when you dissect it out, some amount of thyroid tissue, it may not be grossly visible, but when Dr. Somnath Roy gives his isotope, it glows brightly in the middle of it. So any uptake in the midline of the neck is not considered pathological, and that would usually disappear after Dr. Soman gives his radioiodine. Now comes the question of a residual disease which has been left behind. So that could be because, number one, the surgeon did not want to take too many risks. The disease was left on the nerve. So if you have a note coming in or it was done by yourself and you feel that by doing that, there is a lot of morbidity, you must remember that thyroid disease, well-differentiated thyroid disease has more morbidity than mortality. The predominant factor which will help you to choose a treatment would be the impact on morbidity. So if you find that it is on the recurrent laryngeal nerve and removing it would entail morbidity, I would not go for a second surgery. On the other hand, if it was an improperly done surgery and this could be removed without too much of a morbidity, then I would recommend that all thyroid disease is taken out and we would go in for a resurgery. So that would be my take on that.
Okay. Thank you, sir. Thank you.
And again, I would ask for the volume of disease there. If it's a very small volume, say a 0.5 centimeter sort of disease left there, it is impossible to find it in an operated bed. So go back in again, the anatomy has completely changed in that area. There will be a lot of fibrosis, impossible to find out a small nodule. So if it is sufficiently big, I would put it like more than a centimeter. If there is gross disease more than a centimeter in a non-critical area, I would definitely go and remove it before I send the patient again to Dr. Somnath Roy.
Thank you, sir. Thank you for this, because it is a very important burning issue in our practice and how we proceed.
Right, Somnath, and it's unfortunate many times these patients have to go back for a second surgery. Many times they are sent here for radio-iodine, but Dr. Roy, being so very astute, he would send the patient over to me once again if he detects anything which will interfere with his radio-iodine. And we would usually help him by removing that thyroid.
Yes, sure. Thank you, sir, for your insight.
Yeah.
Go ahead.
Somnath, can I add one or two things?
Yes,
to what
sure.
Arun has said. Yeah,
sure.
As Arun has very rightly pointed out, I'll tell you one thing. There are two or three very important points regarding iodine, radio-iodine therapy, iodine scan, radio-iodine therapy, post-operative residual disease, and then the further treatment. For thyroid cancer, for all practical purposes, the staging of a thyroid cancer becomes complete when we perform the first post-therapy whole body radioiodine scan. And after surgery and radioiodine therapy, if we see there is some uptake, some concentration of iodine in the neck, that does not mean that it is definitely a residual disease. We can say that it is residual remnant thyroid tissue with or without disease within, because the concentration of radioiodine in thyroid cells, thyroid tissue depends on sodium iodide importer molecules, and primary thyroid cancers strangely do not express enough sodium iodide importers on their cell surface, so those lesions are photopenic. But metastatic thyroid cancers, if it spreads to a lymph node or any other tissue, they are very, very radioiodine avid, and they express high degree of sodium iodide importers on their cell surface. So what we see after surgery in the neck, if there is some uptake, so there will be some amount of remnant residual thyroid tissue, and there may be some thyroid cancer affected tissues or thyroid cancer cells very intimately mixed with the normal tissue. And if it is an entirely normal thyroid residue, then also it is very, very important to ablate it, to destroy it completely with something like radioiodine, because that will bring the robust marker of the follow-up of differentiated thyroid carcinoma, which is thyroglobulin, to the baseline level. So in subsequent follow-ups, we can do serial follow-ups of the patient with clinical examination, thyroglobulin antibody, and other investigations. So if the residual thyroid is not entirely ablated, and if thyroglobulin remains at a higher level, which may be falsely elevated thyroglobulin due to presence of remnant physiological thyroid tissue, which is not always possible to remove entirely, as it is very sticky. Maybe, as Arun has rightly mentioned just now, it may be stuck to some other structures, so it may be there. And then if you can't remove it, can't ablate it totally, it may remain falsely elevated. So to bring it down to the baseline 0 or near 0 level, as close as possible to the baseline, complete total ablation of the residual radioiodine uptake in the neck is mandatory. Thank you.
Thank you, sir, Dr. Rai, for again these thoughts in the discussion. So go ahead. Next slide, please. So these are the all common indications where RAI is typically not recommended. Already Dr. Rai is mentioned. It is classical thyroid cancer less than 2 centimeter, intrathyroidal disease, unifocal disease, or multifoci of less than 1 centimeter. No detectable anti-thyroglobulin antibodies, and post-operative thyroglobulin is normal level and negative post-operative ultrasound. These are the common when we are not using RAI in this particularly this category of cases. Otherwise, more than 4 centimeter gross extrathyroidal extension disease with a thyroglobulin level of 10 and bulky disease more than node positive, 5 node positive disease, definitely RAI typically recommended in all cases. So next slide, please. So what is the standard dose of RAI in your hospital setting, and how is the response to monitor? So again, my question is, Dr. Somendranath Rai, what is that your standard dose of RAI at the baseline, and how you escalate, and how far we can go? And as per theoretically, we can go above 600, 700 millicurie. So how far we can go? Please, insight, Dr.
Yes. So, for this, there different institutions follow different protocols. There are different recommendations, like the recommendations from NCCN, recommendations from ATA, recommendations from British Thyroid Association, if several European Association of Nuclear Medicine guidelines, Society of Nuclear Medicine North American guidelines, but we have our own institutional protocol that after surgery, we perform, if the patients are operated outside, when the patients are referred to either head and neck surgery, or they come to our department directly after surgery. If the surgery is performed outside the hospital, we usually always review the histopathological slides. That is very important. And along with that, we perform a baseline ultrasonography of the neck to find out whether there is any gross residual disease in the neck or any lymph node which looks abnormal but was not touched. Then once those structures are taken care of, and then the patient is ready for consideration of radioiodine therapy, we take into account the histopathological features, the findings in the post-operative pre-therapy radioiodine scan. And thyroglobulin is not mandatory at that stage. Thyroglobulin and thyroglobulin antibodies at that baseline level may not be an absolutely essential requirement. But if you have that value, and if it is abnormally high, if you take those, if we taking all those features into consideration, you decide the dose of the radioiodine. If it is only for ablation of the residual thyroid tissue without any adverse features, or without many adverse features, a patient can get low dose of radioiodine starting from 30 to 50 to maximum 100 millicurie of radioiodine, depending on the uptake characteristics. Lesser is the uptake in the neck, more is the requirement of radioiodine by simple law of mathematics. Lesser uptake, if the patient requires radioiodine, and if the uptake in the neck is less, that does not mean he or she will require lesser dose of radioiodine. He or she will require more dose of radioiodine, because if you give 100 millicurie and uptake is 1%, patient will get 1 millicurie. So if the uptake is 0.5%, to deliver the same dose, the patient will require higher dose. So taking everything into consideration, the histopathological features, the imaging features, and the other associated features, we decide the dose. So if it is only for relevant abrasion, it is less than 100 millicurie. If only central compartment nodes are involved and nothing else is involved, no other adverse histological or imaging features, the patient can still be treated with 100 millicurie, maximum up to 100 millicurie. If there are involvements of multiple lateral compartment nodes, it's an intermediate risk disease. We can go up to 150 millicurie. And if it is a high risk disease with distant organ metastasis, the patient will require at least 150 or higher than 150 millicurie of radioiodine. And if it is a multiple disseminated bone disease, if there is no other contraindication and multi-organ involvement like bone, lung, liver, brain, or any other organ, they are involved, then the patient can be given 200 to 250 millicurie radioiodine. Usually, in a single shot, we don't go beyond 250 millicurie radioiodine, and the cumulative dose you are allowed to go up to 1 to 1.2 curie of radioiodine therapy if there is no obvious adverse effects of this cumulative radioiodine treatment, especially bone marrow toxicity. And obviously, if the patient is in the reproductive age groups, other factors are to be taken into account. But a patient who is having disseminated disease, even that factor becomes secondary. The saving the life becomes more important. And if the patient continues to concentrate radioiodine, that is one of the better options for treatment of differentiated thyroid carcinoma. And as I think Joydeep has mentioned in his presentation. So now some schools of thoughts are there that, beyond 600 millicurie cumulative dose, you can think of coupling a TKI along with radioiodine. If the patient continues to concentrate radioiodine, you will couple both the things together. At least try to consider coupling both the things together. If not, you can go for TKI. So that's the thing we do. That's the SOP we follow in our institution.
Okay, thank you, Dr. Rai, for this, because we know this 250 is a millicurie. We cannot give a beyond that because of the toxicity and this patient's profile. So my another question is, if patient is after completion of therapy, maybe after 2 years, because thyroid cancer is a long good disease and a good biology, so we have the long time follow up. So after the completion of radioiodine scan and radioiodine therapy, if patient is on follow-up, now suddenly once patient comes in the regular follow-up to OPD and go to the Dr. Pratik, and there is a nodal disease, it's a recurrence in the neck, which is basically mild symptoms, not so symptomatic. So in that case, and other parameters is normal. Is there any role, or is there any when to give salvage surgery like other head neck tumor? We usually do surgery first in the salvage settings in the recurrence. In this case, particularly differentiated thyroid cancer, when can we consider surgery, salvage neck dissection, or any salvage surgery in this case? Dr. Pratik, please.
So it depends upon what is the size, how is the node. If it's a single node and patient has already undergone a bilateral neck dissection in previous surgery, the lateral compartment was already addressed, then you can just take out that node and consider the patient for radioiodine treatment. But if in the initial surgery, if the lateral compartment was not addressed, in that situation, it would be better that you go for a bilateral neck dissection in that situation. But before taking any decision about neck dissection, you should always get a cross-sectional imaging of the neck and the chest to know, as Dr. Arun has already said, that it is possible that you will have disease at unusual sites as well. So it is always better that if you have a recurrent node in the neck, to go for a cross-sectional imaging of the neck and the chest to see if there is this residual disease or a recurrent disease anywhere else in there, which can be addressed surgically. And then you can go ahead with radioiodine treatment depending upon the final histopathic report.
Okay. Thank you for Dr. Pratik for your thoughts regarding this. So moving ahead, we have next please. So next please, it is already discussed. This is already discussed in the previous Dr. Joydeep's talk. Next slide. So next slide. So molecular testing, basically just I want to highlight one thing. Although the recommendation was there for do a BRAF testing and NTRK testing and all the targeted therapy was available and tumor mutational burden, but usually we are not doing routinely in our day-to-day clinical practice because these NTRK fusion inhibitor is not available. BRAF fusion inhibitor is not available outside clinical trial, and if it is available, it is a very high cost. So 99% of our patients can't able to afford. So usually we are not doing molecular testing, although the guidelines and recommendations should do in the radioiodine refractory cases for do all these tests, molecular testing. But we can do in a similar way and different way in a patient when there is a reimbursement or when there is patient is affording, then we can do. But I think it is not. It is still a discussion of theory and not in the practical aspect. So I keep in behind regarding this. So it is only theoretical. Next slide, please. It is already discussed. Next. Consider the radiation or IMRT in thyroid cancer. I think Dr. Joydeep has already mentioned the role of radiation is limited in thyroid malignancy, which particularly differentiate thyroid cancer. When there is a loco-regional, we have the loco-regional control of the disease, not surgically salvageable. In that case, we can consider radiation in the local area, not for the control, not for the disease as such. Next is. So these are recommendation. EBRT is recommended for patient with a gross residual or unresectable locoregional disease. That's why I am telling he is radioiodine avid. Is in that case we can give. Otherwise, next please. Should not routinely use an adjuvant therapy after complete surgical resection. This all of us know. Is already discussed. Next please. So moving ahead, the investigations, and I think it is already discussed. So my another questions of to Dr. Kapila. Dr. Kapila is there, I think. So is if patient is came with us with a recurrent thyroid cancer with a salvageable neck surgery is done and patient is radioiodine refractory, we started some TKI in this case. In that case, later case, can we consider again if patient is recurrent TKI, again there is progressive disease on the locoregional recurrence. In that case, again we can consider surgery in radioiodine refractory patient on TKI. In this case, just I have to search for Dr. Kapila, please.
Yeah, see, radioactive refractory, as we have usually when a patient comes with radioactive refractory disease, first investigation of choice would be obviously a PET CT. And if in PET CT, if we do find a locoregional disease and it is amenable to surgery, we would go ahead with surgery and try and salvage. However, if that is unresectable in terms of location or it's in a distant metastasis, it's unresectable, then we don't have no other option. We proceed with TKIs. So after TKIs, and if we on follow-up, again, the patient has, if the patient at any point has a resectable disease, yes, it would definitely benefit the patient of trying and giving surgery as an option to reduce the disease burden. But I don't think we have come across any case as such where we were able to salvage.
Okay.
Yeah.
Okay. Thank you, Dr. Kapila, for these things. Moving ahead, next, please. So I think we have almost the last of our discussion. The patient is in follow-up. CT scan shows lung nodule is there, 1.1 centimeter lung nodule. As Dr. Joydeep is also already mentioned, if patient is radioiodine refractory present with a metastatic disease, if it is a low disease burden, patient is asymptomatic, we can observe or surveillance in this case. But if patient is a very symptomatic with disseminated disease with high symptom for the metastasis site, we can consider, we can offer radioiodine refractory case in the acquired TKI, either lenvatinib or sorafenib in the first line setting. Next, please. Next. Next. So my last question to Dr. Arun is, I also think in this is, if patient is on TKI and is there any possibility to give later radiation in this case if patient is in good symptoms, disease control with a TKI? My query, although you are not this kind of things, but just if any thoughts of Dr. Arun, please.
Yeah, see, the indication for radiotherapy will essentially be palliative. Right?
Yes.
Now, palliation would depend on where the disease is. One of the areas where radiotherapy actually works very well is in a bone metastasis. And
Yes.
resultant pain can be controlled very well with radiation. So keep that option in mind because as medical oncologists, many of the time patients are referred to you with metastasis all over the bone. And if the patient is in pain, probably radiotherapy, and that to a very short course of radiotherapy is going to give significant benefit. Now, radiotherapy to the chest, again, sometimes thyroid metastasis is disseminated. It's like miliary. It comes in the entire bilateral lung fields, and they grow to a significant extent before the patient begins to have symptoms. So to intervene in a small growth and give radiation is not something I would recommend. But on the other hand, if it is a single nodule, large nodule, or maybe one or two nodules, which have a potential for causing symptoms or have early symptoms, in those situations, if radio-iodine, patient is not radio-avid, iodine-avid, then maybe there is a role for radiotherapy in these patients.
Yeah.
But otherwise, there is no role for radio in a lung metastasis.
Yeah. So fair enough. So I just wrap up in this case in this session. But I'm sharing my experience. One cases I referred from head and neck OPD almost 9 to 11 months back. Patient is an extensive disease, papillary thyroid cancer, and N3 node encasing the carotid, and multiple disseminated disease. So surgery is not possible, and he is not willing for definitive surgery also. So we started as a palliative intent with a TKI lenvatinib because there is not amenable to surgery. If not amenable to surgery, not a candidate for radioiodine scan and subsequent therapy. So we started TKI in this case. Although it is a single case, not any significance, but just I share my experience. Patient is 11 months post start of TKI, is doing well. The neck nodules and size is regressed, and quality of life is better, and he is tolerating well with a 20 milligram dose of lenvatinib. That is maybe sometimes we can facing in some problem in our OPD where there is nothing to do. We can offer some patient with a lenvatinib as a palliative basis. Although it is not a evidence-based practice, but I just share my experience, nothing else.
So I think Dr. Joydeep shared the experience. It's very interesting to see that we now have an option in these patients.
Yes,
right?
yes.
It's not all very disappointing. And from even with anecdotal evidence, with your own experience, which you presented, we have seen that a certain subgroup of patients do very well with these TKIs. Now, can it be given blanket? Do you have to look at certain molecular alterations before you start them? Are all questions for the future. Because even though the cost is coming down, it's not a matter of cost. It's giving a rational treatment to a patient. So if we may know that certain patients would benefit more with these, but for the time being, these two scans are very, very convincing. They're very they have the cosmic trial and the decision, right? Because the two studies which Joydeep presented. So it brings a new molecule into our clinical practice. And I think, now as experience grows, we will know the right indications. Should we give it when it is small, or should we wait for the tumor to grow till they become symptomatic? Are all questions which we will find answers in future.
Yes, sir, definitely. And as Dr. Joydeep mentioned, the lots of generic is available, and cost is around 7,000 per month in the lenvatinib, and sorafenib is 2 to 3,000 per month cost of therapy. So we not all patient, but definitely some group of patient we can offer this kind of TKI in this patient, definitely. So I think that we are end of our discussion. So any questions from our eminent panelists or any further issue, please feel free to discuss in this forum. So any questions from our panelists, please. So any question in the chat box, Himanshi, please say see. Any question from in the chat box or any questions? Himanshi, please coordinate.
Yes, sir. So at your extreme bottom, you'll be able to see Q&A, sir. If you can click on that, we have 2 questions, sir. If you could answer those.
Please, please.
So Dr. Somnath, can you read them? So I think,
Just I am also trying to read.
So the question is, if the patient is, it's from Dr. Jandad Ahmed, it says if patient is not willing for surgery and radioiodine therapy and cannot afford, shall we go with TKI?
Yes, definitely. If patient is not willing for surgery and radioiodine therapy, we can give the TKI, but intent will be the entirely palliative. We explain the patient regarding the benefit of doubt. We can offer some treatment like TKI, definitely, but as such, there is no evidence for this, and it is not so strong data is also there. So it is a very palliative intent, and we can offer definitely, but out of evidence-based practice.
And Dr. Jandad, if the patient is not willing for surgery because of the cost, I think we may well do to counsel the patient that even TKI treatment may cost as much as the surgery of the radioiodine. So there he may not have an option to choose in terms of cost, because TKIs as things stand today, even though things are getting better, are still expensive. Another question is from Dr. Muhammad Basilatullah, who asks whether what is the dose for EBRT for gross residual disease? I'm not a radiation oncologist. If someone can sort of help Dr. Muhammad here.
I think Dr. Roy, if any comments regarding this.
EBRT.
EBRT treatment for gross residual disease will only be applicable in case of unresectable tumor and for palliative intent treatment. But I'm sorry, I can't comment with confidence what is the exact dose which is administered in radiotherapy, EBRT, if EBRT is considered for palliative intent treatment for gross unresectable residual disease. And the dose I don't know. I'm sorry.
Okay. So thank you, Dr. Rai. So if there is no more questions and if there is no other discussions, so we can wrap up. And
there are a couple of more questions. Somnath, I think there's a couple of more questions in the Q&A.
Yes, please.
So someone has asked about for iodine non-avid with thyroglobulin of 15 nanogram per ml, will PET-CT scan be helpful to detect the lesions? See, I would say that PET-CT is used, but how many percentage and how many cases will it discuss? I think Dr. Soman will probably tell us better.
Yes, please.
So.
Yeah, I think, see the standard. Hello.
Yes, sir, we can hear you.
Yeah.
Yes, continue.
Yeah. So if the if the patient is not having any iodine avid abnormal focal iodine concentration or iodine avid disease in the first or any follow-up scan, and thyroglobulin is elevated, say for example in this case 15, then we will have to perform some other imaging. And so a baseline ultrasound is recommended at that stage, because the first thing first, you will have to rule out or you will have to detect if there is any abnormal neck node. And if it is not there, the next best investigation would be to perform a whole body PET CT. There are two things again. You may require any metabolically active disease, which is non-iodine 131 avid. And another thing is that the next favorite site for metastatic differentiated thyroid cancer would be lung, and there will be multiple small nodules with or without a PG avidity. And now, in how many percentage of patients PET CT will detect it? It cannot be said definitely, but the literature says, taking everything into consideration, all imaging modalities together, that PET CT detection rate yield is maximum, taking into consideration ultrasound, CT, other cross-sectional imaging, and PET CT. The detection rate is maximum with PET CT, and the yield becomes higher if the TG level is higher than 10 nanogram per ml.
Okay. So thank you, Dr. Rai, for your inputs regarding PET CT and these things. So, Dr. Kapila, any other questions?
There's one more where they've asked, how should we manage elevated anti-thyroglobulin antibody levels with the normal thyroglobulin? Again, I think Dr. Somnath Roy will answer this.
Yes, I think the more this question is more towards indicating our tunnel syndrome or these things where there is a non-avid PET CT scan with increased thyroglobulin. Dr. Rai was the best person to highlight this.
Yeah, actually, anti-thyroglobulin antibody makes our life difficult, because if anti-thyroglobulin antibody is high, then thyroglobulin, our very robust and reliable friend in following up a differentiated thyroid cancer patient, becomes defunct, ineffective totally. So, in that case, what happens? Thyroglobulin antibody becomes a de facto marker, because if it continues to rise in the absence of residual thyroid tissue, post-operative residual thyroid tissue, if everything else is okay, but TG antibody is rising, you can again suspect that something wrong is there with the patient. And as you can't depend on thyroglobulin because it is suppressed by raised thyroglobulin antibody, you will have to do other things like a good clinical examination, a very meticulous ultrasound examination of the neck, and other imaging. So, for example, if there is remarkable rise of thyroglobulin antibody in the next follow-up, and if ultrasound is normal, clinical examination of the neck is normal, then you should perform either a CT thorax or a PET CT to rule out lung met, whether there is any asymptomatic lung met is there or not. Means if thyroglobulin continues to rise, means you can't rely on thyroglobulin. So you will have to go by clinical examination and other imaging modalities to detect any recurrence or progression of the disease.
Thank you so much. Thank you so much, Dr. Rai. So, any other questions, Dr. Kapila?
So we don't have any more questions.
Okay, so if we don't have any more questions, so thanks. We have come to the end of our session. So again, thanks to all of us, our panelists, our speaker, and the entire organization team, and the entire the Dr. Reddy's and labs and the other sponsors. And I'll thank to Himanshi and the entire Covina Creation team for organizing a good event in this update on thyroid cancer. With all of these things, I conclude and vote of thanks to all of us, all the panelists, and conclude the session and today's session. So good night, everybody. Stay safe. Good night.
Thank you.
Thank you.
Thank you, Somnath.
Thank
Really
you.
enjoyed.
Thank you. Good night.